Have you ever tried to solve a complex puzzle, maybe one of those massive 1,000-piece landscapes?
Oh yeah, this can be brutal.
Right. And you're just agonizing over this one specific section. You're staring at the board, completely convinced that the piece you need, it just has to be in the box.
Like it's hiding under a flap of cardboard or something.
Exactly. But then you look down and you realize the most important piece, the one that actually unlocks the whole image, wasn't in the box at all.
It was on the floor.
It had fallen on the floor, way outside the frame that you were so intensely focused on.
Yeah, and it's incredibly easy to get so tunnel vision on the immediate problem area that the wider environment completely fades out.
Totally.
We see this cognitive trap everywhere, but in diagnostic medicine, I mean, falling into that trap can actually cost a patient their life.
And that is exactly what we're getting into today. Welcome to today's deep dive, everyone. We are opening up a really fascinating medical text today called Extra-Articular Signs in Differential Diagnosis.
It's a great paper.
It really is.
Yeah.
So for you listening, our mission for this deep dive is to explore what diagnosticians call step 4 of their framework.
Right.
We're looking at how stepping outside the obvious problem area, specifically looking outside the joints when a patient comes in with severe joint pain, is often like the secret shortcut to diagnosing severe systemic diseases.
Because when someone has debilitating joint pain, the natural instinct, for both the patient and the clinician, is to focus entirely on the joint.
It makes sense. It hurts there.
Exactly. You look at the swelling, you order the x-rays, you test the range of motion. But step 4 demands that you pull back.
You have to zoom out.
You do. It requires the understanding that these are systemic inflammatory diseases. They are coursing through the blood, which means they're leaving breadcrumbs all over the body.
Okay, let's ground this with a real scenario from the text. We will call it case 001.
Okay, let's hear it.
So we have a patient presenting with what looks like textbook rheumatoid arthritis, or RA. I'm talking chronic additive symmetric joint pain. Yeah, she has that classic morning stiffness that dictates how she starts her day.
Yeah.
The inflammation is affecting both small and large joints, and she even has a history of heel pain.
I mean, if a doctor is looking purely at the musculoskeletal system, they are probably writing down RA on the chart and just moving on.
Right. The joint profile is remarkably convincing. It hits almost all the major clinical criteria for rheumatoid arthritis.
If you stop at the joints, the diagnosis feels like a closed case.
But here's where that puzzle piece on the floor comes in. The doctor decides to do a full physical exam and notices a faint, slightly raised rash across the patient's cheeks and the bridge of her nose.
Oh, wow.
Yeah, it's almost butterfly-shaped. And notably, it completely spares the folds beside her nostrils. But the patient mentions she just assumed it was sun sensitivity. She wasn't even going to bring it up.
See, that assumption that it's just a mild sunburn is the pivot point for her entire medical future.
Really? Just the rash?
Just the rash. What this text highlights is that this single, seemingly unrelated detail could completely upend the RA diagnosis.
Because it might not be a sunburn.
Right. Is it just a sunburn, or is it a highly specific extra-articular clue pointing to a completely different, potentially life-threatening systemic disease?
So to figure out how doctors decode clues exactly like this one, we're going to trace the path of these diseases through the body. We'll start on the surface, move into the sensory equipment of the head, and then dive deep into the hidden internal organs.
That's a plan.
Starting with the skin and the mucosa, the surface clues.
The skin is definitely the logical starting point. I mean, it's the body's largest organ, it's highly vascular, and it is just this massive, incredibly reactive canvas.
A canvas that displays internal inflammation.
Exactly, for anyone trained to read it.
Let's decode our patient's rash, because the text highlights this as a pattern of the day. That symmetric butterfly-shaped rash that spares the nasal folds is incredibly specific.
It is, and the reason it spares those folds is that they are shaded from the sun.
Oh, interesting.
Yeah, whereas the rest of the cheeks and nose reacts severely to UV light.
So if you combine that butterfly rash with mucosal ulcers, maybe some sudden hair loss, and vasculitic skin lesions.
Which are spots where the tiny blood vessels in the skin have actually become inflamed and burst, by the way.
Right. So that whole cluster, that is genuinely diagnostic for systemic lupus erythematosus, or SLE.
Seeing that full cluster means the joints are almost secondary. The skin has already handed over the diagnosis. It's a textbook presentation of lupus.
That's wild.
But the skin offers other shortcuts too. Take psoriatic arthritis, for example.
Okay.
A patient might have agonizing swollen joints, but the definitive diagnostic key is a single scaly psoriatic skin patch.
And the text points out these patches can hide in places the patient wouldn't even think to mention.
Exactly.
Like they might have a dry, flaky patch on their scalp or even deep inside the umbilicus, the belly button.
Right, because a patient with a swollen knee is never going to complain to a rheumatologist about a dry patch on their scalp.
You wouldn't connect the two.
Never. They categorize those as two completely different problems. The clinician has to actively hunt for that hidden puzzle piece to connect the skin condition to the joint condition.
I am trying to wrap my head around another disease the text brings up, dermatomyositis.
Oh, that's a fascinating one.
The cluster of surface clues for this disease is just wild. Previously, I might have thought of a disease as just a generic feeling of being unwell, but dermatomyositis paints this highly specific, almost undeniable visual pattern on the patient.
The visual signature is quite distinct, and it's the underlying mechanism that creates that pattern.
Let's walk through it because it sounds almost like a bizarre superhero costume or something.
Kind of, yeah.
First, the text mentions Gottron's papules, which are these raised, scaly bumps specifically on the knuckles.
Right.
Then, a heliotrope-colored rash around the eyes, so this distinct purplish hue. Then there are mechanic's hands, where the skin on the fingers gets all cracked, hyperkeratotic, and thickened.
Like you've been turning wrenches in the freezing cold.
Exactly. And finally, a shawl sign, which is this widespread rash draped across the shoulders and upper back.
So what links all those bizarre symptoms together is how the disease targets blood vessels in very specific environments.
How so?
Well, dermatomyositis loves to attack the capillaries in areas of the skin that are stretched over extensor surfaces, like the knuckles.
Oh, yeah.
Or areas heavily exposed to UV light, like the shoulders and upper back. That's why you get the shawl sign and the Gottron's papules.
And the mechanic's hands.
That happens because the inflammation disrupts the normal turnover of skin cells on the fingers, leading to that thick, cracked appearance.
So that makes the visual signs functional rather than just random.
Exactly.
But the text also warns that not all surface clues are that generous. Some just scream inflammation without giving you a specific address.
Right, the non-specific findings.
Like subcutaneous nodules, those little fleshy lumps under the skin.
Yeah, those nodules are incredibly non-specific. You find them in rheumatoid arthritis and lupus.
And osteoarthritis too, right?
Yeah. Yeah, you see them in standard osteoarthritis, like Heberden's and Bouchard's nodes on the finger joints. But they also form in gout, sarcoidosis, rheumatic fever, and even dyslipidemias.
Wait, dyslipidemias?
Yeah, which is when abnormal cholesterol levels cause fat deposits to clump under the skin.
Wow. Okay, so the same goes for erythema nodosum.
Huh.
The text describes these as red, painful lumps, usually showing up on the shin.
Yes, very common.
And they are often accompanied by paniculitis, which before I read this, I had no idea what paniculitis was.
Most people don't.
It's actually inflammation of the fat layer sitting just beneath the skin.
Right, and both of those conditions appear alongside several different inflammatory diseases. They are alarm bells.
Just general alarm.
Exactly. They confirm that the patient's immune system is mounting a systemic response, but they don't hand you the final diagnosis like the dermatomyositis pattern does.
Got it. You also see Raynaud's phenomenon, where the blood vessels in the fingers clamp shut in the cold, turning the digits white and then blue.
Right, and when that pairs with actual thickening and hardening of the skin, it points specifically to scleroderma.
They would get into leg ulcers and purpuric lesions, which are purple spots caused by bleeding under the skin. Those can show up across RA, lupus, polyarthritis nodosa, and Behçet's disease.
Which brings us to Behçet's.
Yes, I want to pause on Behçet's because this leads to a really fascinating clinical tool, the mucosal ulcer pain scale.
The distinction in pain levels for these ulcers is a very elegant diagnostic tool.
So the text maps out this pain scale for ulcers occurring in the mouth or genital areas. It states that in lupus, the ulcers are moderately painful.
Okay.
In the spondyloarthritis group of diseases, they cause very little pain.
Yeah.
But in Behçet's disease, they are severely painful.
Right.
But I have to push back on this methodology, though.
Oh, how come?
Well, pain is incredibly subjective, right? Like, I might stub my toe and think I need an ambulance while someone else breaks a finger and just tapes it up.
That's a fair point.
So how can a doctor use something as unscientific as a patient's personal pain tolerance to distinguish between lupus and Behçet's disease?
That is a very common concern when dealing with pain scales, but in this specific context, the clinician isn't asking the patient to rate the pain from 1 to 10.
What are they doing then?
They are looking at massive clinical extremes. The mucosal ulcers in spondyloarthritis, they are often entirely painless.
Really? Entirely?
Yeah, a doctor frequently discovers them during a routine exam because the patient had absolutely no idea they were even there.
Oh, wow. So we talk about a complete absence of sensation versus actual agony.
Exactly that. The ulcers in Behçet's disease are characteristically devastating. They interfere with basic biological functions.
Like eating.
Yeah, the patient cannot eat, they struggle to speak, they can't drink water without severe distress. So while pain is subjective, the gap between I didn't know that existed and I haven't been able to eat solid food in 3 days is a highly reliable diagnostic canyon.
Okay, that clues it up completely. It's the functional impact, not just a number on a chart.
Precisely.
So moving inward from the skin and mucosa, the inflammation doesn't stop. It travels into the head. Let's look at the sensory equipment. The eyes, ears, and nose.
The head houses highly sensitive, structurally complex tissues. When systemic inflammation reaches these areas, the risk to the patient's quality of life just skyrockets.
The text highlights sickest symptoms first. Severe chronic dryness of the eyes and mouth because the immune system is attacking the moisture-producing glands.
Which is the absolute hallmark of Sjögren syndrome.
Right, but it can also be a secondary complication in RA, lupus, and systemic sclerosis.
True.
What I found amazing, though, was how the text maps the anatomy of the eye to different diseases. It's almost like each disease has a preferred target within the eye's architecture.
The specificity is remarkable, isn't it?
It really is.
The eye isn't just one uniform block of tissue. It's composed of different layers with entirely different blood supplies and structural proteins.
Which is why different autoimmune diseases attack different parts.
Exactly.
For instance, rheumatoid arthritis specifically attacks the sclera and episclera, the tough white outer part of the eye.
Right.
But spondyloarthritis bypasses the outside and goes for the uvea and iris, causing uveitis.
Yep.
And then lupus and systemic vasculitis go straight to the back of the eye, causing retinal lesions.
And inflammatory myositis actually targets the eye muscles themselves.
So why the difference? Why do they pick different targets?
It comes down to what the disease is looking for. Rheumatoid arthritis primarily attacks collagen-rich tissues, like the capsules surrounding your joints.
Okay.
While the sclera of the eye is also heavily composed of that exact same dense collagen, so the RA antibodies attack it by mistake.
Wow.
Spondyloarthritis, however, is heavily linked to vascular inflammation, so it targets the uvea, which is the intensely vascular, nutrient-rich middle layer of the eye.
That makes perfect sense. They are hunting for specific proteins or vessel types.
Exactly.
And then there's granulomatosis with polyarthritis or GPA.
Yes. GPA.
GPA causes retrobulbar lesions, which are inflammatory masses forming behind the eye that literally push the eyeball forward out of the socket.
A condition called proptosis.
Right. And it also attacks the middle and inner ear. Which brings us to an incredible vault entry for this deep dive. Relapsing polychondritis.
The cartilage-specific patterns here are devastating.
I was trying to conceptualize relapsing polychondritis.
Yeah.
Imagine like a highly specialized termite.
Okay.
This termite doesn't care about the drywall, the wiring, or the plumbing in a house. It only eats one highly specific type of structural wood. Relapsing polychondritis is like that termite, but its target is cartilage.
Right.
It inflames the ear cartilage, causing a floppy, deformed pinna known as a boxer's ear, and it eats away at the nasal bridge cartilage, causing a saddle nose deformity, where the bridge of the nose literally caves in.
It is a profound structural collapse, but this introduces a major differential diagnosis problem. Yeah, as the text notes, GPA granulomatosis with polyangiitis can also result in that exact same saddle nose deformity.
Right. If relapsing polychondritis and GPA both result in the identical visual of a caved-in nose, how does a doctor figure out which mechanism caused the damage?
Good question.
Like, if the visual endpoint is identical, how do you differentiate?
You look at the method of destruction. You have two very different diseases underneath that identical visual.
Okay.
Relapsing polychondritis, your termite, targets cartilage directly. GPA, however, acts more like a bulldozer.
The bulldozer.
Yeah, it destroys cartilage through granulomatous inflammation, meaning it creates these aggressive, chaotic masses of immune cells that essentially crush and obliterate everything in their path, not just cartilage.
So because GPA isn't a picky eater, it's going to leave collateral damage everywhere else.
Precisely. Remember that GPA affects the middle and inner ear and causes those masses behind the eyes.
Oh, right. The proptosis.
Yeah. Relapsing polychondritis generally sticks to the structural cartilage of the outer ear and the nose, so you follow the wider trail of destruction to figure out whether you're dealing with a specialized termite or a reckless bulldozer.
Man, following that trail of destruction takes us deep underground. We need to move from the visible face and head into the hidden systems, the internal organs.
This is where these diseases graduate from painful to potentially fatal.
Yeah.
When systemic inflammation begins to compromise major organs, the timeline for medical intervention shortens dramatically.
Because the clues here are invisible to the naked eye.
Invisible, but they are the most critical.
So the text starts with the genitourinary system. It compares reactive arthritis to a gonococcal infection.
Yeah, that's an important distinction.
A gonococcal infection produces an insanely specific combination. Urethritis, inflammation of the cervix, migratory polyarthritis, meaning the joint pain jumps from one joint to another, and tenosynovitis located specifically on the back of the hands.
It's a highly recognizable pattern. But the gastrointestinal overlaps are where we find one of the most dangerous diagnostic traps in medicine.
The IBD versus Behçet's trap.
Yes.
Inflammatory bowel disease, specifically Crohn's disease more often than ulcerative colitis, is known to cause inflammatory polyarthritis.
Right, the bowel is inflamed, and so are the joints.
But the text warns about Behçet's mimicry. A patient comes in with intestinal lesions. The doctor sees them, checks the GI symptoms box, writes down IBD, and stops looking.
Which is a huge mistake.
Right, because actually the patient has milder features of Behçet's disease. They also have those agonizing mouth ulcers, the red lumps on their shins, and eye inflammation.
Yep.
If a doctor just ticks the GI symptoms box and stops looking, doesn't that prove that standard medical checklists can actually be dangerous? Like, they miss the whole picture, right?
It absolutely does. This highlights a fundamental flaw in how medicine is sometimes compartmentalized. If a specialist treats a symptom check as a solitary task, it is dangerous. A gastroenterologist might look at the bowel, see the lesions, and say, "My job is done, it's IBD."
But they didn't check the mouth or the eyes.
Right. Because Behçet's is a systemic vasculitis. It's an inflammation of the blood vessels everywhere in the body. If you don't connect those bowel lesions to the eye inflammation and the mouth ulcers, you are going to put the patient on the wrong treatment protocol.
And getting the treatment protocol wrong is catastrophic when we reach the renal and neurological system.
No, absolutely.
The text refers to these as the high-stakes clusters. Kidney and nerve involvement running alongside polyarthritis are massive red alerts.
Because the kidneys and the nervous system are highly vulnerable to vascular inflammation. When they start to fail, the entire body's equilibrium collapses.
The text mentions significant proteinuria, up to nephrotic syndrome, and rapidly progressive glomerulonephritis.
That's a mouthful. Let's break that down.
Yet, to translate that out of the medical jargon for you listening, the kidneys are essentially a massive network of microscopic biological filters called glomeruli.
Right.
When diseases like lupus, antiphospholipid syndrome, or ANCA-associated vasculitis attack those filters, they become inflamed and tear. That's glomerulonephritis.
Exactly.
And when those filters tear, large essential proteins leak out of the blood and are lost in the urine. That's proteinuria and nephrotic syndrome. The body is literally draining its own building blocks.
And neurologically, the damage is equally mechanical. You see conditions like mononeuritis multiplex.
What exactly is that?
Well, this isn't just a general numbness. This happens when systemic vasculitis actually chokes off the blood supply to individual specific nerve cables.
Wow.
Yeah, so a patient might suddenly lose the ability to lift their right wrist and the next day lose sensation in their left foot.
It sounds terrifying.
It really is. It is an asymmetrical, terrifying loss of function.
Then we have the lungs. Lung involvement is very common with RA, connective tissue diseases, sarcoidosis, and ankylosing spondylitis.
Very common.
But the text zeroes in on a terrifying clinical subset called pulmonary renal syndrome, where the lungs and the kidneys fail together simultaneously.
Yeah, it's a dire situation.
This is triggered by lupus, systemic sclerosis, ANCA vasculitis, and Goodpasture syndrome. Why do the lungs and the kidneys so often go down together?
Think about what the lungs and kidneys actually are. I mean, both organs rely on massive, intricate beds of tiny capillaries.
Okay.
The kidneys use them to filter waste from the blood, and the lungs use them to exchange oxygen into the blood.
Right.
So if a patient has systemic vasculitis or circulating immune complexes acting like debris in the bloodstream, those millions of fragile capillaries act like nets.
Oh, I see.
Yeah, they catch the inflammation, they clog, and they rupture. The two largest capillary networks in the body are destroyed by the exact same circulating storm.
That makes the connection so vivid, they're just huge filters getting clogged.
Exactly.
Okay, one last hidden system to cover. The hematological clues. The blood itself.
The blood often provides the earliest, quietest clues before the organs begin to fail.
The text points out that if a routine blood test shows low platelet counts, a doctor should immediately suspect SLE, or antiphospholipid syndrome.
Right.
And if a patient is in a hypercoagulable state, meaning their blood is abnormally clotting and causing blockages, that is a massive red flag for antiphospholipid syndrome.
Because an unexpected blood clot or a low platelet count might be the very first whisper of an autoimmune disease, long before the joints even start to hurt.
That's crazy to think about. We've tracked this from rashes on the face to collapsed nasal cartilage down to kidney failure and blood clots. Let's pull all of this back to the single patient waiting in the exam room, case 001.
Right, the patient with the textbook rheumatoid arthritis joint profile and that faint butterfly-shaped rash on her face.
We know the joint profile fits rheumatoid arthritis perfectly, but that rash completely disrupts the narrative.
It sure does.
What is the resolution? Is it RA or is it lupus?
Well, at this stage, a good diagnostician embraces the uncertainty.
They just accept they don't know yet.
Exactly. The rash might be the genuine extra-articular clue that pivots the entire diagnosis toward SLE.
Okay.
That means the doctor needs to order different blood work, check the kidney function for proteinuria, and look for those low platelets.
Yeah.
Or it really might just be an unrelated sunburn. The point of step 4 is that the clinician is now investigating the whole picture rather than just the aching knees.
Real-world medicine isn't about feeding isolated symptoms into an algorithm and getting an automatic answer. It is about building a comprehensive toolkit and constantly challenging your own assumptions right up until the end.
You have to be willing to follow the clues, even if they lead you out of your specific area of expertise.
Which brings us to a final lingering thought for you to mull over today. We've spent this entire deep dive looking at how a single underlying flaw in the immune system can manifest as a skin rash, a collapsed ear, torn kidney filters, or migrating joint pain.
It's all connected.
It really is. If a single biological error can look like 50 completely different diseases depending on what tissue it touches, it really makes you wonder if our entire system of naming diseases is fundamentally outdated.
That's an interesting point.
Right. We still name diseases based on where they hurt. Rheumatoid arthritis for the joints, dermatitis for the skin. But if the body operates as one single, highly reactive, interconnected web, maybe we aren't dealing with hundreds of different diseases at all. Maybe we are just looking at different coordinates on one massive spectrum of immune dysfunction, just waiting for medical science to finally zoom out far enough to see the whole puzzle.